My name is Melvin Samsom. Currently I'm the Chief Executive of the Karolinska University Hospital. By background I'm a gastroenterologist. I did my medical school in Ghent in Belgium and in Utrecht in the Netherlands. Well, Karolinska is a merger from two university hospitals within Stockholm. The University Hospital located in Huddinge and the Karolinska University Hospital located in Solna. I think that one of the most important decisions that was made a couple of years ago is that at the Solna site there had to be a new building erected, and that's called Nya Karolinska Solna. That's a very large university building that really helps us to provide high-end specialized medical care for our patients. Take it in two parts. One is of course the physical building, which is completely new, has single rooms, hybrid operation rooms, a lot more connectivity between the different areas within the hospital. Connected to that, we also changed the way we are organized. So we're now in the classical way organized with divisions and departments, and we will work in a more thematic way, and we will really be organized around the pathway of the patients. This is a crucial period that we're in, that we are changing the way we are organized, that we are introducing a few basic principles as value-based healthcare to go back to the basis again. We have become more highly specialized, which is our assignment, of course. And along that pathway, we have become more fragmented as well. So I think that's really one of the issues that we need to deal with in the future. I think, for instance, if you take the treatment of chronic patients, we see that we can create new platforms that not necessarily need to be within the university hospital environment, but in close connection to us, which is another way of providing healthcare for a very large group of patients with chronic diseases. One of the important questions that we as the leadership from Karolinska ask ourselves is, are we going to move into the new premises and keep our current organizational structure? Or are we going to use this opportunity to really rethink the way we want to be organized in the next 5 to 10 years? We are now organized in different clinics at Karolinska. We have about 60 different clinics, so a patient travels from one clinic to another clinic to another clinic. And we know that that causes fragmentation. So we decided to fundamentally restructure ourselves along the pathway of the patient throughout the organization. So the basic principle is that we dissected out all the patient groups that we have at Karolinska, and we now have analyzed it. We are around 400 different patient groups. For this patient flow, there will be a patient flow captain appointed. That's a line responsible person. So we are going to work in a thematic way, and we're going to leave the clinical structure, and we're going to move in the new organizational structure in the new building. If we talk about introducing value-based healthcare, restructuring our organization, moving to our new premises, I think it's very important to regard this as a journey. We start off, of course, first with sharing them internally within our organization to make sure that it makes sense, that we are gathering the right data, that we are measuring it in the same way, and then, of course, take the next step and share that with the community. I think that transparency is really an opportunity to improve ourselves in that respect. We are now about 1.5 years on our way. We started really introducing basic concept of value-based healthcare. We are now increasing the number of patient flows that work along this line. At the end of this year, we will approximately have 30% of our organization working along this way. If you look at the way Sweden has been working with it and Karolinska, we measure a lot of outcomes. We have a lot of indicators that are partly process indicators and partly outcome indicators. We are now in the process of really looking at these indicators in very much detail. So do they make sense? Are they still valid for the things that we're currently doing? So we are updating them, we are renewing them, and at the same time, which is also quite different from the way of working today, we want to have them very timely. So if you look at the open comparison, we're looking at data from 1 year ago, and we want to have the data from yesterday to really help us to steer the organizations. If you look at our assignment, it's highly specialized care. And then the next obvious question, of course, is, so are there treatments that you do and it's not in the highly specialized care arena? Yes, that's the case. And that's part of the future healthcare plan, that we concentrate on more highly specialized care. And if you go back again to our equation of value-based healthcare, it's adding value defined by quality and costs. And if the quality that we provide is similar to the quality of another acute hospital, but our costs are higher, our value equation goes down. So it makes a lot of sense that we're really focusing on these patients where we can really add quality and connecting costs. We have a view on that. We will, for instance, move out outpatients about 260,000 in the next 2 years to other hospitals or to other care providers. We will go down about 10,000 inpatients in the next 2 years, really to focus on that. When you involve patients more in the hospital environment, the first question is, of course, where do we create the opportunity for them to have a meaningful input? One of the basic fears of doctors and nurses is that when you ask patients to come closer, to get more of the ideas of patients, that they will increase their demand on healthcare, which they cannot deliver, which might frustrate our co-workers. In general, and in my experience, that's often not the case, because patients very well know the pressure that hospitals are under. They know that doctors and nurses do have a very difficult task and have long working hours. If you open up your organization for patients so that they can reach you via email, via SMS, or whatever you want to have as a communication channel, we have to be organized in such a way that we can receive it and that we can also timely respond to this. Well, I've cut down quite substantially in my meeting time. On average, when I meet people, it's not longer than 30 minutes. And I've more or less halved all the larger meetings that I have. So I think that's really setting or trying to set a good example in this. The way we balance it, the way I balance it, is to have the proper discussions at the executive table, to really make decisions about directions, to really follow it up, and to be sure that you have the right mindset around the table, and to really have a common goal. For instance, in the university hospital, that research and patient care should be connected, that what we get out of research should be implemented in the clinical arena, or the questions that we have from the clinics should be investigated in some kind of research agenda. And I think that really helps to cope with the difficult assignments that we have. And education, it's such a basic part of what we do in an academic center. It's so important that we constantly realize that the people that we start educating now will be working in healthcare probably until 2050 or 2060.